I would like to, first of all, what is the biggest barrier current to achieve integrated care? Okay, so it probably is about number one. There are three components. One is obviously the appropriate funding, because as been highlighted, most of the service are being public service have not been funded in order to provide integrated care. There mostly there are barrier, exclusion criteria, and so on. Number one. Number two is also the training, because again, as we also me highlighted, there is a lack of specific training at many levels during the training, and that's another critical issue. Clinician need to become more confident on that, and that's our probably the biggest one. So funding. And as well, probably I would say, as our colleague from Headspace highlighted, also this changing landscape about the NDIS, the funding arrangement, that's make even more difficult. That will be but if Karen or Gabriella want to add anything else.
I don't know if you want to mention this one, Gabby, but I guess one of the things that we really struggle with is, I guess, the specialty services, whether it's, disability, medical, mental health, just having that interagency, multi-service integrated care is just so lacking. And we do see that same thing that you guys were talking about, Natasha and Faye, of, clients being pushed between different services because of funding restrictions. It's like, this isn't us, this is them. And because people start getting quite protective of resources, but also, there is some anxiety, I think, for a lot of services in their own training and experience and how comfortable they are stepping into this space and advocating in whichever direction. I've definitely experienced where, I've even been told at times that I'm, stepping into someone else's space. So I think there is a lot of anxiety, particularly around autism, what I've noticed in WA, that makes people kind of stay in their own lane and not necessarily provide integrated care or, I guess, advocate for assessment and, further treatment for some of these clients.
Second, if I can also answer quickly to the second question, no, currently there are very limited funded government funding assessment service for SD over 60, very limited. Even under 16 are very difficult to access. There are long waiting list, but even in the private sector at the moment, the waiting time is extremely long. So quite expensive and costly assessment. We are probably lucky that we can, due to this project that we are doing, we'll probably be able to offer to our client because, again, the co-occurring mental health condition is actually the norm, not the unusual. And I personally believe, and our team believe, that you can't address their mental health if you don't address also the neurodiversity or neurodevelopmental, underlying neurodevelopmental condition, or at least need to be part of the framework in the intervention. And that's where I really like the comment of, I think is Beth, where, team, unfortunately, this is what I experience also here, that sometimes people are rejected or separated or not accessing mental health care on the basis of the co-occurring neurodevelopmental condition. That's definitely a major issue that I personally believe should be changing, need to be addressed, because that's it's unequal access to services.
Yeah, I was gonna just sorry,
yeah, go ahead.
Just gonna jump in. Just completely agree with everything you're all saying, and that we haven't both found an answer to that challenge. But I guess our attempt to elevate things back to good care and bring things back to basic care, and say you cannot formulate or provide good care to somebody and put their identity aside. And that if neurodivergence isn't kept in the picture, you actually risk doing a lot of harm. And this space, I think there's lots in it around the specialization of different areas, like autism being seen a specialist and eating disorders a specialist. And actually the interplay in eating disorders is a perfect example that when there is neurodivergence underlying, the reasons driving it and the response needed can be really different. Yes, I think just a huge need for advocacy and all of us continuing to kind of think together and work in that space.
Totally agree.
Yeah,
Really.
I agree too, and I think in multiple levels as well. So not just in terms of the clinician working directly with that young person, but when we kind of look at training and frameworks and policies of the organisation and how we do assessments, because it's impossible to separate the person and their identity from the mental health in terms of understanding them on a holistic level. Change is needed across all levels.
Absolutely. And just have to finish with Ettore last comment, and then we'll have a comfort break.
Yeah, my last comment is basically on the fact that also we are, one of the things that I would like to probably to see in the future, we are doing a cost analysis, because obviously not providing holistic care actually increase the overall spending in terms of longer admission, especially when there is an interface with eating disorder and neurodiversity. That's our client that stay longer in inpatient unit. There are no service that they can easily get manage the co-occurring condition. So that's what we see, and I think this is what we want to do. And Naomi, we are very glad that we joined our forces with you, because that has been so far a fantastic journey. And thank you for the opportunity to show what we're doing here to your colleagues and our friends in UK.
Thank you, Ettore, and thank you all. Really appreciate your time. I know it's towards the evening now in Australia, so we may not see you towards the end of today in the UK on this webinar, but we do appreciate you and thank you. Any questions that are in the chat that we've not been able to answer now, we'll hopefully be able to come back to at some point in the near future as well.